Welcome to the Creative Commons RX podcast. Before diving into this episode, I want to ensure we're all on the same page. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this podcast is at the user's risk. The content on this podcast is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the audio content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.
Welcome back to the deep dive. Today we are focusing on a molecule that it really embodies the razor's edge of modern medicine. It's digoxin. It's a cardioactive steroid that's been a powerful treatment for things like heart failure and atrial fibrillation for a very long time. But its power comes with this monumental risk.
The therapeutic index.
Exactly. It's incredibly narrow. I mean, imagine having almost zero margin for error. That's what we're talking about with digoxin.
Yeah, that tiny window means understanding the drug's potential toxicity is, it's just as important as knowing why you're giving it in the first place.
So that's our mission for this deep dive.
Right. We're diving into material from comprehensive toxicology training. We want to give you a clear map of what's happening. We'll unpack the molecular mechanism, which is actually pretty surprising.
And we'll distinguish between acute and chronic poisoning.
Yep. Identify the patients who are most vulnerable and, most critically, detail the treatment strategies, including one substance that, in most emergencies you'd reach for. But here you have to avoid it at all costs.
Okay, let's jump right in at the cellular level. To really get the danger here, we first have to understand what a healthy, relaxed heart cell looks like.
Well, normal cardiac function relies on keeping the inside of the muscle cell very, very different from the outside. And this is all managed by this constant electrochemical effort.
Okay.
The key piece of machinery is called the Na plus K plus AT pace pump.
The sodium-potassium pump.
Exactly.
Yeah.
And you can think of this pump as the cell's primary bailout system. It's always running, actively pushing sodium ions out and pulling potassium ions in. This whole process makes sure the cell maintains a really low internal sodium environment.
So the key is keeping sodium low inside the cell. Why is that specific gradient so important?
Because it creates the power source for the next critical step, which involves something called the sodium-calcium exchanger, or NCX. This exchanger absolutely relies on that low internal sodium to work. It uses the tiny bit of sodium that leaks back in to power the removal of calcium. And getting that calcium out is what allows the heart muscle to fully relax after a contraction. It's a beautifully choreographed system.
Okay, so now let's unpack digoxin. Its primary action, and this is where it gets dangerous, is that it reversibly inhibits that fundamental pump.
The Na plus K plus AT pace pump.
It just jams the whole bailout system.
Exactly right. And when that pump is jammed, sodium ions start to build up inside the cell. They just have nowhere to go.
Right.
This rising sodium concentration immediately weakens the power of that sodium-calcium exchanger. So suddenly, it can no longer effectively pump calcium out of the cell.
And I remember reading that if the sodium gradient gets strong enough, that calcium pump can actually run in reverse.
It can, yeah.
Yeah.
And that leads to a net influx of calcium and a really significant accumulation of it inside the cell.
And now we can see why digoxin is a medicine in the first place. That bigger pool of stored calcium means you get a more forceful contraction.
That's the positive inotropic effect.
Right, which helps in heart failure. And because of some vagal stimulation, it also causes a slower heart rate.
The negative chronotropic effect. It slows and strengthens the beat. That's the goal.
But the toxicology twist.
The twist is what happens when that intracellular calcium becomes excessive. When the drug level gets too high, the amount of calcium overload is just dangerous. It makes the heart muscle electrically unstable, highly reactive.
A state called myocardial sensitization.
Precisely. The heart tissue becomes, twitchy. It's ready to fire off these spontaneous, dangerous rhythms instead of waiting for the proper signal.
That instability is literally the line between a life-saving medicine and a poison. So if that's happening inside the cell, what's the first sign we see in the patient that we've gone too far?
What's really fascinating here is that the toxicity presents mainly through rhythm changes. and they often start, very subtly. The most common cardiac abnormality is actually sinus bradycardia,
So just a slow heart rate.
a heart rate that's too slow, from that enhanced vagal action.
And beyond just slowness, you see the classic conduction problems, like atrioventricular blocks, AV blocks.
Right, the signal gets delayed or even blocked between the top and bottom chambers of the heart.
And then at the really severe end of the spectrum.
That's when that myocardial sensitization takes over. You see life-threatening rhythms, things like ventricular ectopic beats, or even sustained rhythms like ventricular tachycardia or fibrillation.
Which basically makes the heart useless as a pump.
Completely. And it's all due to this increased automaticity, the ability of that ventricular tissue to just fire on its own.
And it's so important to stress, not all symptoms are cardiac. I mean, chronic toxicity, that gradual buildup, can look like almost anything else.
Oh, yeah.
We're talking severe, nonspecific GI issues, right? Nausea, vomiting, no appetite. And big neurologic issues, fatigue, confusion, even delirium.
It's a huge diagnostic challenge for clinicians because the symptoms are just so vague. But there is one really memorable detail.
The visual symptoms.
The visual symptoms, exactly. Patients often report seeing colors differently. Chromatopsia, the classic one is xanthopsia.
Xanthopsia, that's the yellow halos.
The bizarre experience of seeing yellow halos around lights or everything just looks, yellowish.
Wow. I can't imagine how disorienting that must be. That would definitely distinguish it from, a simple stomach bug. Okay, let's pivot to the patient. Who is most at risk for this?
You can really group them into three main categories. First, and this is a big one, is advanced age.
Because of kidney function.
Exactly. Digoxin is mostly eliminated by the kidneys, and as we age, renal function naturally declines. The drug just clears more slowly and it accumulates.
Which leads right to the second factor. Any kind of renal insufficiency.
Right, whether it's acute from, say, dehydration, or it's chronic from an underlying disease. Any drop in kidney function is going to impair elimination and cause that internal level to rise.
And the third factor.
It's simply having underlying cardiac disease. I mean, these are the patients who need the drug, but their hearts are already compromised, their electrical systems are more sensitive, so they're just far more vulnerable to the drug's arrhythmogenic effects.
So beyond those big structural risks, there are these powerful chemical traps. This is where other medications and the patient's own chemistry can just push them over the edge.
That's right. You have to think about electrolyte disturbances, low potassium, low magnesium, and high calcium.
Hypokalemia, hypomagnesemia, and hypercalcemia.
Right. They all dramatically potentiate the toxic effects.
So why do these imbalances have such a huge effect?
They alter the cardiac cell membrane potential. Most critically, low potassium hypokalemia makes it easier for the digoxin to bind to that NIS plus K plus ATPase pump.
Oh, interesting.
If there's less potassium competing for a spot, the drug gets a tighter grip on the pump. You get enhanced toxicity even if the drug level itself isn't crazy high.
And then, of course, drug interactions. People just assume if their doctor prescribed it, it's all fine, but common meds can block the clearance and cause levels to spike.
Absolutely. You have to watch out for the common culprits. Certain macrolide antibiotics, quinidine, verapamil, imidazole, which is ironically also an antiarrhythmic. A patient could be stable for years, but a new course of an antibiotic could suddenly interfere with the metabolism and send their levels soaring.
It's a silent interaction that puts them in the hospital. Okay, this next part is critical. The difference between acute and chronic poisoning, especially when it comes to potassium.
This potassium difference is, well, it's really the clinical hallmark. Acute toxicity is usually a single massive ingestion and overdose.
So symptoms come on fast.
Usually within 6 hours, yeah. And in these cases, hyperkalemia high potassium is very frequent, and it's a powerful predictor of a terrible outcome. If you see potassium climbing in an acute case, it's a huge red flag that the cellular pumps are shutting down, and you need the antidote now.
But the whole picture just flips with chronotoxicity.
It flips completely. Chronic is that gradual accumulation we talked about, often from declining kidney function. The symptoms are slow, insidious, nonspecific.
Yeah, and potassium.
And here, hypokalemia low potassium is often what you see, especially if the patient is on diuretics. And what's crucial is that sometimes in a chronic case, just giving them potassium to correct that low level can temporarily stabilize the heart.
Even before you fix the digoxin level.
Right. It buys you time.
Okay, let's touch on the drug levels themselves. The therapeutic range is tiny, but you're saying a single number doesn't tell the whole story?
Precisely. You have to treat the patient, not the number. If someone feels fine, but their lab is a bit high, You monitor them. If they're confused, vomiting, and have a dangerous rhythm, you treat immediately no matter what the number says. The clinical picture and the potassium level are far more important.
Which brings us to treatment. How do we neutralize this stuff?
The primary antidote for both acute and chronic poisoning is digoxin-specific Fab fragments. We just call it DS-Fab.
Okay, Fab fragments.
Yeah, they're these engineered antibody fragments. They're incredibly effective and incredibly specific.
So how does an antibody fragment actually pull the drug out of the system?
It's actually brilliant. You infuse it, and the Fab fragments circulate and bind tightly to the free digoxin molecules in the blood.
So it neutralizes them on the spot.
Instantly.
Yeah.
It prevents the drug from binding to any more of those NOT plus K plus AT paste pumps. The Fab digoxin complex it forms is big and stable, and the whole unit just gets safely filtered out by the kidneys.
And this antidote isn't just for the prescription drug, right? It works on natural poisons, too.
That's correct. It has broad application. It's effective against poisonings from plants that have these cardiac glycosides like foxglove, oleander, even lily of the valley.
That's incredible. But this antidote is also really complex and notoriously expensive. How do doctors make that split-second call to use it when they might not even know how much the patient took?
It's a huge challenge. The dosing really depends on either the ingested amount, which is, often a guess, or the serum concentration, which might not be accurate yet.
Because the drug is still distributing.
Right. So because of all that uncertainty, empirical dosing is really common. You might start with a lower initial dose, maybe 2 vials, and then you just watch the patient. You monitor them, and you repeat the dose until the cardiac symptoms resolve. The clinical response drives the treatment. Even severe acute neurologic symptoms, that digitalis delirium we mentioned, if the toxicity is rapidly getting worse, you treat.
So supportive care is key, fixing the electrolytes. But now we're at that critical contraindication you flagged at the start. Tell us why we must avoid calcium salts in a digoxin overdose.
This is maybe the most important clinical takeaway for you today, and it links right back to the beginning. The whole mechanism of digoxin poisoning is excessive intracellular calcium.
Right.
Their heart cells are already swimming in it. If you then give intravenous calcium salts, you are just flooding the system even more.
And the result of that?
You risk making the toxicity worse. You could directly cause a severe, maybe fatal arrhythmia, or even a cardiac arrest. You are literally adding fuel to the fire.
That feels so counterintuitive because calcium is often used to stabilize the heart in other situations with high potassium, like from kidney failure.
And that's the paradox. It's the right move in a different scenario. But in the context of digitalis toxicity, the risk of worsening the underlying cellular problem is just too profound. Expert recommendations are overwhelmingly conservative. You avoid calcium because the theoretical risk is just too great.
One final alert about the treatment. Once you give the antidote, you have to stay vigilant. The Fab fragments can cause a really rapid drop in serum potassium.
Especially if the patient was hyperkalemic to start with. Post-treatment monitoring is paramount. If potassium drops too fast, you risk causing new problems. So you have to be ready to catch and correct that rebound hypokalemia.
We have covered a remarkable, very high-stakes journey today. We learned that digoxin inhibits the heart's bailout pump, forcing a dangerous calcium buildup. We know hyperkalemia is the grave danger sign in an acute poisoning, and the Fab fragment is the antidote. But you must never forget that critical warning: avoid giving calcium.
That complexity, where this tiny chemical change can flip a life-saving drug into a deadly poison, it's just astounding. We focus on pharmaceutical digoxin, but like we said, these cardiac glycosides are everywhere in nature. Foxglove, oleander.
Right. And the Fab antidote works against those natural poisons, too, which raises a really important question for you to consider. Given how effective this specific antidote is against both pharmaceutical and natural poisons, what new avenues does this open up for treating unexpected toxic exposures? Think about disaster settings or remote areas where you just don't have specific countermeasures available.
It really does change the entire response toolkit.
A fascinating thought to end on. Thank you for joining us on this deep dive.
Continue to explore, continue to learn.
We'll see you next time.
This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this podcast is at the user's risk. The content on this podcast is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the audio content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.